Right. Awesome. I will turn it over to Molly Gamble to begin today's broadcast.
Thanks, Abby. Welcome, everyone, to today's webinar, Characteristics of High-Performing Hospitals, Why Data Transparency is the Foundation for Success. I am Molly Gamble at Becker's Hospital Review. We'll begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We look forward to hearing your questions. We will also have a series of audience polling questions today during the webinar. When we reach each poll question, the question will pop up automatically on your screen. Our speakers will then give you a few seconds for you to select an answer from the options on your screen and then click Submit. We thank you in advance for your participation. Also, please make note of the additional resources located on your webinar console. You can find supplemental content for today's program, as well as a link to schedule one-on-one time with an IBM expert on this and other transformational hospital topics. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access that recording. At this time, it is now my pleasure to start today's webinar by introducing our moderator. Betsy Block has more than 20 years of experience in healthcare marketing and strategic planning for community hospitals and academic medical centers. Her areas of expertise are in the development and implementation of clinical integration programs, as well as the physician alignment platforms needed for optimal performance under value-based care. She has architected solution-oriented business development strategy for value-based care and partnered with senior healthcare leaders and physicians on implementation of new models of care. Prior to joining IBM Watson Health, Betsy was an executive partner for value-based consulting at the Advisory Board Company, where she managed relationships with key strategic accounts as well as designed consulting engagements to address the most salient client needs. At this time, I am pleased to turn the floor over to Betsy to begin today's presentation.
Hello, everyone. Welcome to our conversations with some highly effective leaders. I'm really excited to discuss with them some of these topics. This is a second in a series of conversations we've had in follow-up to a study that IBM Watson Health conducted in late 2019 and early 20. We were able to interview 9 executive leadership teams. We actually interviewed them in person, obviously pre-COVID. And these leadership teams were multi-year winners of the 100 Top Hospital Award. And we really wanted to understand what are those characteristics and practices that highly effective leadership teams employ, and then what are those things that we can quantify and share with others who also want to be as effective as leadership teams. So if you're not familiar with the 100 Top Hospital Award, there is more information on our 100 Top Hospitals website about our methodologies and our winners. But let me summarize it to say that there is a single point in time where a hospital organization is evaluated, but it's also the award winners are also able to improve their performance over time against their peers. And it is that combination that we find incredibly compelling, because these organizations can't just rest on their laurels of performing well in one year, but they have to constantly strive to improve and to be pushing their leadership teams to improve. And what is incredible about the 2 leaders that you're going to meet here in just a few minutes is that both of them are multi-year winners. And when I say multi-year, they are systems that are a bit of rock stars because they've won 8 times each of their systems that they have worked with over that time frame. So we are talking with some leaders that have real credentials and real experience in stretching teams over the long haul to continue to perform and improve their performance over time. So a little bit about study that we conducted, and just for some background, one of the first things that we noticed, these are the 9 hospitals across the country, and one of the first things that we noticed is that multi-year winners did not necessarily come from hospital systems who were in fast-growing markets with lots of commercially insured patients. In fact, some were, but others were challenged with declining populations and growing numbers of elderly and growing numbers of unemployed. So what we found was, in interviewing these leadership teams, it was a lot more than just the circumstances that surrounded them that allowed them to be successful. So clearly, we had to dig deeper to find what is it that was sort of the magic that helped these leadership teams excel over time. And this is just a quick summation. We're not going to spend a whole lot of time on it. As I mentioned, it is on our 100 Top hospital website if you want to go there to look a little bit more into this study and our findings. But what was clear is that these organizations who were multi-year winners were highly engaged leaders. They were very invested in our conversations. They have a framework of nursing excellence. Whether they are magnet winners or not, they use a very stringent approach towards nursing excellence. They had a focus and an emphasis that we found was a bit unique from their board level down. So most of these organizations talked about that the time their boards spent discussing their quality performance and this expectation of that was clearly important. What it appeared was an emphasis on quality above financial performance. So that'll be interesting, I think, to talk to some of our presenters today about that. But today's focus is really in that fourth finding, which was around data and benchmarking and how that is used to help drive their performance improvement. And that's where we're going to spend a lot of our time today talking about that. But also sort of tied with number 5, both of our presenters are part of systems, a little different shapes and sizes of systems. But what we found was that most of the multi-year winners were part of systems that have grown in the last few years, either adding folks or not. And it is interesting to understand how those systems then also drive some of the performance improvement initiatives of those hospitals and how they're changing in order to sort of accommodate being a high performer themselves, but also bringing up their fellow system hospitals who may not be performing at the same level, and how they're learning and challenging and growing together. Innovation, our finding around innovation was that it's very practical. There's not necessarily an interest in innovation just for innovation's sake, but really for those, it's really vetted and tested in terms of how does this help us with our mission. So that mission focus with regards to innovation was still very important. And then ultimately, and this was the focus of our last presentation, was around culture. It's going to be difficult to even talk about any of this to not discuss culture, because these winning systems clearly had a culture that we described it really as a camaraderie and an esprit de corps. It didn't mean that everything was sunshine and roses, but an openness to openly discuss maybe situations that they felt they didn't handle well, but this comfort level and trust that is difficult to quantify, but important to understand that that was fundamentally a part also of what we found in interviewing these leaders and these leadership teams. But you want to meet these folks because, as I said, they're superstars. Carol Coupland is president and chief nursing officer for St. Luke's University Hospital in Bethlehem, Pennsylvania. And I know, Carol, that you have had probably a pretty stressful 5 months, as most leadership teams have. So really appreciate, though, that you in that sort of unique role of having two C-suite leadership jobs during this time. I'm sure that it has been busy for you, and we look forward to hearing from you, and we really appreciate you giving us that some time today to share your insights. And then Paula Sullivan, as I mentioned, both of these systems are 8-time winners of the 100 Top Hospital Award. And Paul from Memorial Hermann has also won our 15 Top Health System Award several times as well. So truly a leadership team of excellence to study. Paul also has 2 roles. So yes, you're not talking to people who are underachievers in any way. Paul is CEO of Memorial City, Memorial Hermann, and also the Greater Heights System Hospital, just 7 miles away. So 2 hospitals during a time, as we know, Houston right now has just been through a very difficult strike and a spike in coronavirus. And so, Paul, for you as well, thank you so much for taking a breath and stepping aside to talk to us about how you do what you do so well.
Thank you. Pleasure to be here.
Yeah, thank you. So in our first question, we wanted to know, and Carol, if you would lead us off here, how do you use data to propel change within your organization?
Thanks, Betsy. I'll be happy to. Data is really, truly at the core of it all because it's what we have to start with in terms of assessing our current performance, whether that is publicly available data or whether it's through our third-party payers or even our internal data so that we can compare ourselves against ourselves, whether historical or locally. But we always start with that so that we can identify our strengths as well as our opportunities, and that then drives the plan or the changes that we need to do. So it's core to all of change.
Paul, how about for you?
Yeah, I would agree with Carol. It is central to our process. If I was to summarize the way we use data very briefly, we connect strategy to data and data to strategy right from the beginning. At the board level, as we look to interpret how we develop a strategy to advance our mission, we look at same kind of things. We look at internal and external benchmark data that allows us to assess our strengths and our opportunities. And then from that data-driven strategy formation process, we drive that down through the organization through a cascading process where there's a consistent use of that data down to the lowest meaningful level in the organization to try and ensure that we are, again, connecting strategy to meaningful measures that will help us achieve the goals that we've set for ourselves.
Mm-hmm. So both of you have to combine, it sounds like. A big part of it is combining all the data sources that you might have available in order to be able to inform your strategy.
That would be correct. And I would also say to be aligned because very much as Paul just spoke of, it's from the board to the staff level so that all of our goals need to be consistent between disciplines as well as administration and medical staff leadership, department head staff. It all needs to be aligned if it's going to work effectively for the long run.
Mm-hmm. So can you describe that a little bit more, Carol? How do you have a very intentional plan for doing that, or does it happen organically because you've been doing it over time?
Well, I would say all of the above, really, Betsy. When I think about when we're presented with some data, let's say on hospital-acquired infections, I'll use a very concrete example. It's important that we recognize that issues are multidisciplinary, and so too are all of the solutions. So the first thing we would do would be to convene a team to look at all of the data to say what are the contributing factors, what are the resultant solutions, and how as a team do we address those. And once we come up with that plan, we set our metrics, and then all of those disciplines, all of those levels use the same goals, come up with their strategies, and evaluate their effectiveness.
Mm-hmm. Mm-hmm.
Yeah, I think to maybe play off some of Carol's points there, our approach is very similar. There's a great deal of work goes into turning what are sometimes very high-level strategic measures of success into something that's meaningful at the bedside every day. And just like many organizations, to play off Carol's example, we have high-level goals as an organization around our infection rates. And through our strategic planning process, which cascades down through the organization, we may set that at a very global incident rate level at an organizational level, and then deliberately take that from a system level goal down through specific goals related to the opportunities at individual care delivery sites, and then in turn down to some process-based best practices that may tie to something like surgical site infections in terms of bundle utilization and that kind of stuff, where successively, through a process of discussion and engagement with leadership and employees at each level, we're having a conversation around, okay, if this is the big X that we're chasing as an organization, what's each individual's team's role in achieving success with that big X, and what are the measures that we can apply to that to ensure that everybody has the opportunity to understand, first of all, what the expectations are, and to have, as well from the data perspective, regular feedback in terms of their success in achieving those things that will lead to the ultimate organizational success and fulfilling our obligation to our community.
So, Paul, do you... Oh, go ahead, Paul.
No, I was just going to add to Paul, because it did trigger a thought for me when you were talking about our board of trustees and spending more time on quality as opposed to finance. They're all really interrelated, and I think our board recognizes that if we measure it and we improve our quality, finances are a resultant improvement of that. It's all interconnected. So that's what we have seen. Regardless of whatever quality metrics we use, it does loop back into a financial improvement.
Yeah, I would agree with you completely on that, Carol. I mean, I think for us, we take very much a balanced scorecard approach to strategy development and measurement of success underneath it. And quality and financial performance and patient experience and physician experience and employee experience, they really are none of those stand apart from each other. It's an integrated set of data-driven strategies that are mutually self-supporting, and generally success in one will lead to success in others. And
I sort of neglected to mention that both of you have been with your organizations for a long time, right? Since you were maybe 3 or 4, something like that, right? But but has that changed over time in terms of your the way you interact with your board or around data, in terms of the transparency with your board about that? Or has it always been that way from your perspective?
I'll speak for Memorial Hermann. Certainly, it's been an evolution over time, and particularly, I guess, the shift that's happened in our organization, and I suspect in many others over the past decade, to particularly the board's awareness of quality and understanding by lay board members of what quality is in a healthcare organization. That was not a 2-year or a 5-year journey. Certainly within our organization, that's been a 10-year plus journey, which began first of all with education at the governance level about the fact that even if you were not a clinical professional, you could have a role in helping drive quality in the healthcare organization. So first of all, we educated our board. We then provided them with time and transparency and governance structures, we'll say through a board level quality committee, where we had the opportunity to provide lay board members an opportunity to understand what quality looked like in the organization, and giving them the opportunity over time to grow in that understanding and to get to a point where today they can ask very, very probing questions about very specific aspects of our performance. And that's been a journey of 10 plus years that I've been fortunate to see evolve through Memorial Herman's eyes.
What I would add to that is I think about Mr. Richard Anderson is the CEO of the St. Luke's University Health Network, and he's been in his position probably greater than 35 years now. And so he has really seen an entire evolution of healthcare. But it was in the early 2000s that Mr. Anderson set the goal that St. Luke's would be in the top decile in the country. And everyone recognized that to be an ambitious goal for a relatively small health network in central PA. But we believed that, again, you shoot for the moon, you might fall amongst the stars, but you're still in that high-performing area. And so we pursued that. I think publicly available data also was a game changer, as well as reimbursement for healthcare, because it was really important that we address all of those areas. And so, again, to Paul's point, we had to start with the education of the board that that information was publicly available, and they needed to understand our performance as it related to that data and what we were doing to continually improve in that process. So I think all of the above really helped us as it relates to the national profile of the data.
Mm-hmm. And I'm curious, was there a time, Carol, that there was some reluctance perhaps to share fully performance results perhaps with the board? I mean, did it also take some work amongst your team to feel more comfortable to share perhaps things that weren't as positive, mistakes?
Yeah, I can't say there was a reluctance. I think that it was more just a discomfort of something that's new. And putting that in that perspective, what we did is we started with our board to do a quality presentation for each one of the boards of trustees, where we would look at a service line and look at their areas and provide that chairman and the service line administrator the opportunity to present to the board directly, so that they could see not only the areas requiring opportunity, but the incredible improvements or performance and the outcomes that we had. So it was really a growth experience for the service line teams, but also gave our board connection with the people who were providing the care. So that has been, gosh, decades now that we've been doing that, and it's appreciated on both ends.
Mm-hmm. Yeah. Was it similar for you as well, Paul?
It was. I mean, providing. Again, I wouldn't say that there was reluctance to share data, but it was a transition that obviously involved some adjustment for everybody, from one where as the board progressively gets more educated and asks those probing questions, to having a level of comfort with that. But that's something as an organization that we. One of our values is courage, and it was, I think one of those courageous things that the organization needed to do to meet its responsibility to the community. We provide very transparent data to our board on, for example, on harm events in our organization. On a de-identified basis, we share a little clinical vignette of every serious safety event that happens in the organization, and obviously those discussions prompt very specific questions from educated board members about what we could have done differently to avoid that harm event in the past. And it's done, rooted in an understanding that to improve, you've got to learn, and to learn, you have to be transparent, and to be transparent, you have to have something to be transparent about, which kind of brings us back to the central importance about making sure we have a rigorous means of capturing and collecting that information, tying it to targets we've set around our strategy, and using it to propel improvement against a backdrop of the understanding that as a community-owned organization, that is our responsibility. That is what we owe our community.
Mm-hmm.
I would also say that we probably had more reluctance of transparency of individual provider information than we did with the service line. So docs were more reticent to say, well, I don't want individual docs performance out there. But even that we have been able to overcome. And today the docs all know what their own performance is as compared to their peers.
Tell us a little bit, Carol, because that's easier said than done. So can you point to something specific, perhaps, that you did to make that feel more open and allow for folks to feel vulnerable with one another about, for example, harm events?
So I would say, in a very concrete example, the number or the volume of CAT scans ordered by emergency department physicians. When we first started to monitor that, we looked at it in aggregate, and then we blinded everybody until everybody had a letter of the alphabet, and then everybody got accustomed to the graphs, and eventually we just put names in there so that docs understood that, presuming all the same acuity, all the same volume, there was variability, and that they could use each other as resources to address that in a constructive, positive way.
Mm-hmm.
And I would add that in Memorial Herman's case, we rooted the process of defining quality in our physician organization, and we specifically gave the charge to our physician organization, which, if I can just explain for a moment, we're in a market, and our medical staffs are a combination of physicians in private practice, employed physicians, and an academic practice that we're in partnership with the University of Texas here in Houston. But all three elements of our overall physician organization come together to help us define quality in specialty groups. So in the same way, to take perhaps cardiac surgery outcomes as an example, we allowed using the framework of data in that particular case that we got from the Society of Thoracic Surgeons for our surgeons across the organization, some of them who practice together, others who practice in competition with each other, to define based on that data where our opportunities were. And just as Carol mentioned there, go through that inevitable process of, number one, establishing trust in the data on a de-identified basis, going through that process of Dr. A through Dr. F, and eventually just through the process of dialogue, the focus on improvement, and I think the natural competitiveness within physicians in the first place, and the fact that they had been given the opportunity to define success themselves in this situation, to a point where now that data is shared transparently and openly amongst each other, where the focus in those discussions they're great. It's about, how do we benchmark off each other to get better.
Sure. So I'd like to now turn it to the audience. We'd like to ask you all this polling question. We'd like to know how effectively your organization communicates data, and then does it vary in effectiveness depending on whether we're talking about communicating clinical performance, financial performance, or patient satisfaction data. And Molly, do you want to help them understand what they need to do in order to be able to answer the poll?
Sure, Betsy. So attendees, we've arrived at our first polling question for today's presentation. And the poll question should pop up now on your screen. We'll extend a few seconds so you can select your responses. Betsy said the question is, how effectively does your organization communicate data about clinical performance? We'll then move to financial performance and then patient satisfaction, with the options being not effective, sometimes effective, usually effective, very effective. So Betsy, there's the response for the first clinical performance part of the question.
Okay.
Here we go for financial. We'll wait a few seconds here. Thank you, attendees. And then finally, patient satisfaction. Okay. There's the results for patient satisfaction. So Betsy, I'll turn it over to you and Carol and Paul for reactions to what you've seen here.
Sure. So it's interesting that financial results, typically you're really 100% of you felt that you're usually effective in communicating that, but more of a struggle here around patient satisfaction data and also clinical data. I didn't know, Paul, if maybe, just in your experience, do you have any reaction to that?
Yeah, I think the findings are pretty typical, I think, and unsurprising that, obviously, historically, as organizations, we've understood the importance of the financial imperatives for a very, very long time. And some of those other dimensions of the data are perhaps newer to both, I guess, in terms of the manner in which you define success. I mean, for me, I really look at this and I go back to that balanced scorecard approach to defining strategic success. And if all you define success as is financial success, then that's what people are going to look at. I think when you elevate other dimensions of performance to the same level of importance in your dialogue in terms of how you share information, and you really have to do that all across the organization, from the governance level to the bedside, out through the physician organization to your medical staff leadership, until they hear you talk about the other aspects of performance with the same level of frequency and the same level of seriousness as you do the financial level of performance. It just doesn't get the attention. I mean, it really is one of those, I guess, attention being the currency of leadership moments, that being intentional about how you define success and sharing those metrics consistently is I think what helps drive the opportunity to get past that barrier of some of the more variable performance that the data speaks to here.
Mm-hmm.
I think
Carol,
I would yes, as I think about sharing the data with the clinicians, that's relatable for clinicians to look at clinical quality and satisfaction, and they can embrace that and realize that they can touch it and they can influence it. As opposed to the finances, which, although they understand and appreciate the importance of that, they're in the business of taking care of patients. And so those truly are their measures of success, and as I said, they can buy into it. And I think very often on our board of trustees, they're very much members of our community. And so they have a very solid financial understanding, but they're also potential patients or family members. And so they can associate with healthcare the clinical quality, and are patients satisfied with the care that they see? Are our employees happy and engaged to work here? They're concrete things that they can associate with, so that I think it's a real positive to be able to look at all those dimensions of clinical excellence or hospital excellence.
Thank you. So I want to move now to talking a little bit more current. Obviously, COVID-19 has really changed a lot, right, in terms of and it's ongoing, right, in terms of maybe the length of time we thought we would be dealing with it, and here we are, and now the prospect of probably continuing to manage your hospital systems, with it as opposed to behind you. But tell us a little bit about, and Paul, perhaps you want to go first. Tell us a little bit about whether that has changed some of your approach to sharing information and data. How have you communicated during this time?
Yeah, obviously the past 5-6 months have been an interesting time for all of us in healthcare. And from a communication perspective, I think what it has really underlined for us is as a community and as a nation, as we've learned to cope with this, we've done that against a backdrop of rapid learning and rapid emergence of new evidence, and that's really has challenged us to hew to some first principles that have all been really important to us. First of all, to be absolutely transparent about what we know and what we don't know, and about the certainties and the uncertainties. So we have, as an organization, we have, and to do that interestingly enough, an environment where we cannot get large numbers of people together in rooms anymore to talk like we might have done historically. So within Memorial Hermann, some of the key steps we've done to address that is, first of all, obviously to acknowledge the uncertainty, to communicate regularly. Dr. David Callender, our president and CEO, in the early months of our pandemic, did a weekly town hall meeting via Zoom for all our employees and physicians. He continues to do that on a bi-weekly basis. And at a local level, at individual campuses to deal with our specific issues, we follow that path. We communicate daily with every employee and with every physician with a quick email on what's going on across the organization. We follow the organization-wide process of conducting town hall meetings and conducting general medical staff meetings via Zoom on a much more regular basis than we have done previously. But all based on what's important to us in the past. I mean, we root our response very much in our values and set them in that framework. And our values at Memorial Hermann are community, compassion, courage, and credibility. So understanding that the response to COVID is a part of what we do as this has gone on, we have to continue to meet the other health needs of the community, and setting our response needs in that context of the COVID response being part of our obligation, but not the totality of it. And ensuring as we do that we are credible and transparent about what we know and what we don't know. Continuing to adapt and evolve as we change, communicating regularly about that, and making sure that we are not just focused on taking care of our community in this context, but taking care of the needs of our physicians and our employees who've obviously been placed under incredible challenge over the course of the past few months as well, and helping them to continue to rise to this as something that, is not a short-term phenomenon, but something that's going to be part of our at least our short to medium-term existence as we meet our obligation to meet the overall needs of our community. So transparency and consistency and regular communication, it's perhaps a truism, but you cannot over-communicate about something like this, and continuing to do that regularly is how we've focused on dealing with the pandemic as it's evolved in our community.
Carol?
Yes, and I would agree with everything that Paul said. As I think about how we address this from a quality and a data standpoint initially, is we did follow our own framework of saying what are the metrics that we need to measure as it relates to this pandemic. And we had to look at volumes, clearly, of patients who were diagnosed. We had to look at employees who were testing positive. And did they test positive related to a hospital exposure, or was it a community exposure? To put some numbers around that so that we could measure our effectiveness with PPE as an example. We had to measure availability of PPE, and did we have it appropriately distributed across the network? We then had to look at our clinical outcomes. This was a game changer for us. All of a sudden, all of our performance improvement initiatives, as we've known them for decades, had to be set aside so that we could look at, again, this is a very specific disease, and we have to deal with patients in very different ways. As a healthcare system, we're used to high touch, high interactions, and now all of a sudden these patients had to be isolated. So how do we measure their outcomes? How do we measure the clinical results that we were achieving? So we did set up a scorecard for this type of an event, and we used it across all 12 hospitals in the network so that we could compare the volumes, the outcomes, et cetera. And to Paul's point, I think the most important thing that we could do is communicate. We did town halls very similar to the ones Paul described. We kept information out there in writing about how much PPE we had available, how many employee exposures we had, patients, any kind of metric we thought that they'd be interested in or would give them some assurance that we were on top of it, we were concerned with it and responding appropriately. And we got a lot of feedback from employees and the board and the community that they appreciated hearing that kind of information.
That's awesome. So tell us, where do you see these opportunities, though, now going forward? Where are some of your biggest challenges as it relates to data as you look to managing? So, Paul, maybe you want to start with that. Tell us about your challenges.
Yeah, I think obviously healthcare is evolving, and we're all across the country at various stages of the continuum of that evolution from volume to value. So of necessity, when you make that transition, your definition of success as an organization is going to change, and that's really kind of here in the Houston market, something that we're focusing on fairly heavily right now. Perhaps one of the slower markets to move towards value. And as an organization and as a market, we're going through that process of dialogue about saying, okay, in a value-driven environment, what do our success metrics need to look like? Do we have a capability to capture some of those things? Have we been giving them the attention that we need to give them? And to take an example of something like, readmissions. Readmissions is something that obviously has become increasingly important in more recent years, but perhaps has an elevated level of prominence in the past two in our market than perhaps it might have had prior to that. As we look not just at success in an episodic sense, which is perhaps where we've evolved from, but looking more from a total life experience and a total the total continuum of patient care, not just in the acute care setting, but in others. And that's reflected in our organization in a transformation towards a service line driven delivery model, where we're not just looking at care in the episodic sense, but looking at it in the continuous sense from a patient-focused perspective as well, and evolving a set of metrics and success factors that help drive success as it's defined in that context.
Mm-hmm. Carol, are your challenges similar? Or different?
And I think, again, that evolution towards the continuum of care and how do you measure the effectiveness of that, and also to deal with the multiple methods of reimbursement. I mean, Paul talked about readmissions and wanting to manage that, and we should manage that from a quality perspective regardless. But from a financial perspective, there's actually a disincentive because we're reimbursed for many of those admissions today. So as much as you want to manage them, and you want to manage them from a quality perspective, you have to prepare for the financial realities of reducing the number of admissions to your acute care facilities. So we're very focused right now on our ambulatory as well as the continuum of care to say, how do we improve quality overall, and how do we even define, forget the measurement, first we have to define it, then we're going to have to measure it. All very positive things, though, for our community and for our network.
Mm-hmm. Excellent. So both of you really mentioned that the defining metrics for value-based care as opposed to volume, and episodic care moving to more really longer-term service line, and I'm assuming you mean service line that goes even beyond immediately after an episode, but really as it extends into care for communities. That's kind of what I'm hearing. Really, how do you define that care over a longer term? And
yes, and I would add to that, Betsy, the whole social determinants and what's the role and responsibility of healthcare institutions in that, because I think we're all coming to a very quick understanding that those are such significant influencing factors on how do we possibly influence those variables since they're so diverse for us.
Mm-hmm. Yeah. So this is our second polling question to the audience. We'd like to ask how similar your data challenges are. If I were asking you that question directly, how would you answer it? Would you answer it similar to those that Paul and Carol have expressed?
Thanks, Betsy. And attendees, we'll wait a few beats here so you can select your responses, and then the panelists and Betsy will react to your responses.
Okay, thank you. So similar about 48% of you, but somewhat similar 48%. So there, and I wish we could have the opportunity to hear a little bit from you, but we can through the Q&A and the chat. So I know we're kind of closing in on that time. So if you do want to define maybe some of the challenges that you have, or refine that a little bit and within the question and answer, we'd love to answer some of those. I'd like to give you the opportunity to ask Carol or Paul some of get their feedback on some of the challenges that you are experiencing that might not necessarily be related to the ones that they brought up. But Paul or Carol, do you have any, I want to make sure we have plenty of time to talk with our audience today. I'm just wondering if you have any sort of final thoughts about data challenges, about the perhaps the availability of data, right, within your organization. You mentioned that you get it from a lot of different sources. Sometimes I think at IBM we also hear we have a lot of data, but we don't always have a lot of interpretation of that data. So I don't know if that's what some of our attendees might feel, but wanted to kind of throw that in there to ask if that's something. Perhaps Paul, does that ever surface within your organization?
Yeah, your remarks there really echoed a thought that was firing in my brain just as you spoke. That we swim in vast lakes of data, and the challenge often is not so much availability of data. It's turning that into relevant, actionable intelligence and deciding which bits of that data are the important ones to focus on. Which is why, I guess from my perspective, the importance of tying your attention to data to your strategic planning process is so important, because we none of us lack for data. I think sometimes what we lack for is understanding which data is the most important one and which we need to prioritize to focus on. And that answer is going to be different from every organization depending on its objectives, with some level of commonality, which I think is what we see reflected in the answers to the most recent question. But as an organization going through that process, right from your governance structure down, of creating that alignment and association between what you as an organization set out to achieve, defining how you measure that, and then turning your resources loose to access that vast mine of data that we all sit upon, to identify which bits of it are the ones we're going to pursue to try and measure that success.
I would agree with Paul. It's so easy to fall into the data paralysis trap, where you get into so much that it's almost difficult to identify what should or should not be on your scorecard. Or you can get into very detailed debates with providers on why the data shows what it shows and all the different nuances and variations. And I think that there is some merit in saying, let's all just stop. Let's pick 2 or 3 metrics that are going to help us get to where we are. We'll get underneath it in terms of the nuances and how to manage it. But let's just agree it's not perfect. It's not going to be perfect, but it's good enough that it's at least directional so that we can show our improvement, our performance improvement.
Yeah. So what I'm really hearing is both of you say that leadership step probably falls squarely within your executive team to take that moment to stop and say, where are we going with this? What are we trying to do with this data? What performance are we trying to improve? And making sure that goal, as it ties to the strategic objectives and the mission of the organization, is all back in alignment. So that's kind of what I'm hearing you both of you say. That is your role. Right?
And don't overthink it, don't overcomplicate it. Let's just get fixing the problem, not interpreting it or analyzing it over and over again.
Yeah, I agree completely. If you can't make it comprehensible enough to put on a wall in a break room where somebody can understand what's important and how are we doing while they're sitting down having lunch, I think it's overcomplex.
Got it. Well, thank you. I'd like to turn it now to opening it up for questions from attendees.
Thank you, Betsy, Carol, and Paul. That was a fantastic presentation. We'll now begin today's question and answer session. So if you haven't yet, please do submit any questions you have by typing them into the Q&A box you see on your dashboard. And we're going to try and get through as many of these questions as we have time for. We have about 10 minutes left. So Betsy, Carol, and Paul, some questions have come in while you were speaking. This first one is for Carol and Paul. Can you please give some wisdom on how to obtain buy-in at my institution on the road to data use and interpretation, and subsequently turning that data into goals and strategy? Carol or Paul, do one of you want to take a first swing at that question?
Sure. Why don't I give an example, one that came very early in our quality efforts. It was something that we had an organizational interest in, the antibiotics within 1 hour of cut time. It was back in the early 2000s. So we had a vested interest in improving that, but we were able to engage the disciplines in it by looking at how do their lives become easier, how does their quality improve based on it, and looking at it that it's not one discipline necessarily. So you put all of the disciplines in the room, so anesthesia, surgeons, nurses, pharmacy, FPD, they can all see how they can contribute to improving that one isolated metric. And we address the issues, we address the problems, we get them out of the way, and we measure them. And that group can then get together on a regular basis to see their improvements and then to truly appreciate how the individual patient improved, but also the overall performance of all of those departments. So I think it's getting that group buy-in to realize that it's no finger pointing, it's a team sport here, and we can improve it together.
Yeah, I would agree, and I would add to that rooting the opportunity in your patient and in your community is key, because diverse as healthcare organizations are, I think pretty much everybody who comes to work at the healthcare organization does that with a desire to come and improve life, either for the community at large or for the patient individually. And you know, whether it's antibiotics within an hour of arrival to prevent infection or any other measure, making that connection between the patient and the data. And then, as Carol said so well, they're setting up a structure that gives people the opportunity to participate and engage around creating a solution, I think is key to achieving buy-in.
Thank you both for your insights to that question. This next one is more of a statement or a perspective that I'd love to hear your reactions toward, and that is this. Have you found that this transparency around data has added to physician stress at all? The elevated focus on metrics is one thing that physicians often express anxiety about. Any reactions to that perspective?
Where I see physician stress related to metrics has a tendency to go around productivity and RVUs. You know, as Paul just said, our docs want to improve quality, and they get it, and it's a part of what they do every day. So I don't necessarily see stress around that as much as on the alternatives with productivity. Paul, I don't know if you've seen something different at your place.
Yeah. I would say not necessarily specific to Memorial Hermann, but I think, you know, any of us, I think, if we were being honest, would say that as data transparency in healthcare has improved, that does create a level of stress. And I don't see stress as a negative word, and I think that's true for physicians as much as it's true for others. What it's also, you know, I think the key is not so much that creates a burning platform or creates stress. I think it's a question about what you do about it, and do you give people who might be challenged by some data that's out there an opportunity to be part of a solution to improve it, if there is an improvement opportunity. But equally, making sure that the data discussion is not always just about the improvement opportunities, but about it celebrating and identifying the strengths and elevating those. So yeah, I think a more transparent environment always carries the opportunity for stress. I think how you frame that and how you give people ownership over using it for improvement, and celebrating the areas where you do those things well, I think helps to channel that call to action in a positive direction.
Great point.
Terrific. So it's about what you do with that data, and also transparency, also celebrating the small wins, Paul, and not just looking for always ways you can improve upon the data.
Mm-hmm.
Yeah.
So speaking of improvements, this next question is about process improvements and how those are communicated to staff. How does staff communicate gaps in process improvements? Do they have a process to communicate this other than sharing it with their supervisor?
I'd like to step in on this one first, because this is something I'm really passionate about, and something that I love our approach to. We a number of years ago implemented an all-employee suggestion scheme, where we set up within our kind of innovation structure a committee at the system level comprised of employees, but also committees at each of our individual hospitals, connected to another data stream. We set up a portal on our intranet where any individual staff member could submit an idea for improvement to this committee. And we created an infrastructure that ensured loop closure, both for ideas that were implemented and ideas that were not. But really about, we preached that message as we've gone through our ongoing service line transformation, that really the solutions to providing better quality care, a better patient experience, and usually as a corollary of both of those things, a more cost-effective and affordable experience for our patients as well. That wisdom resides at the bedside much more than it resides in the C-suite. And again, it's that process, I think, of empowering everybody across the organization to provide them a place to share that idea. And to ensure that there's loop closure on that sharing is something that I think is critical to engaging people in that process. And for us, it's been something that's been highly successful.
I think those are great ideas. Another example that I would give, when we were looking at improving medication errors or decreasing medication errors, we convened a group of high-performing RNs who were known for their quality of care, and we had them come together as a group to identify what are some opportunities for improvement. They were able to identify those, pilot those, identify the most effective strategies, and then we would take them network-wide. It was so effective in that we've used it for other quality issues that have come up. And I think the other thing that I would say is we just always need to continually recognize that staff have a factor in this. So we do quality awards here that allow people to identify an issue, solution, outcomes, and we submit those for a quality award across our network, which has been very successful in elevating the importance of quality across the network.
Thank you so much, Carol and Paul, for your answers and insights to these questions. Betsy, before we conclude, I want to turn it over to you to see if there's any closing remarks or anything you wanted to add.
I just want to thank both Carol and Paul again. Their insight and their ability to lead their organizations during what has been a historically stressful time is quite remarkable. And once again, I want to thank both of you for your commitments, because I know your communities are a lot better off for the work that you do. And I appreciate all those of you who are listening. We'll take some of your questions and we can pass them along. And perhaps if there are some other insights that Carol and Paul can share, we will follow back around with you. I know we didn't get to everyone's questions today. So thank you all for joining. And we will hope to talk to you again soon.
Thank you, Betsy.
Yes, thanks attendees for your questions and for your poll responses. Also want to thank Betsy, Carol, and Paul for this excellent presentation, and the IBM Watson Health team for sponsoring today's webinar. For more information on today's content, please check out the additional resources on your webinar console, and don't forget to fill out our survey. Enjoy the rest of your day, and we look forward to having you join us for future webinars. Thank you.